Welcome to Work Participation in Older Workers, a systematic review of interventions. We're glad you're here. My name is Angie Hunt, Project Manager with Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to CIRPD. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they are available. As I mentioned, my name is Angie and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Yvonne Steenstra. Dr. Yvonne Steenstra is the Manager Research and Analytics at Mornell-Chappell. Yvonne was trained as human movement scientist at the Groningen University and as epidemiologist at VU University in Amsterdam. He obtained his PhD from the Department of Public and Occupational Health at VU University. He received a postdoctoral diploma from the CIHR Strategic Training Program on Work Disability Prevention at Sherbrooke University. The focus of his study and research has always been on work and health. His interests focus on predictive modeling and implementing evidence in practice related to work and productivity. He has co-authored over 40 peer-reviewed publications and presented at numerous international conferences. And now I'll hand it over to Yvonne.
Okay, so welcome to the webinar. It's a privilege to present. I'll just go on to the first slide. So I'll first introduce Mornell-Chappell, my new employer. I started working here in November last year. So Mornell-Chappell is really, there's a Morneau part of this company and a Chappell part of this company. So Morneau is quite known in Canada for a lot of its actuarial work and so it's pensions and benefits. Where Chappell is quite well known in Canada for its employee assistance programs, where we're the largest provider of employee assistance programs in the world, actually. And there's over 4,000 employees, so that's pretty big. And we're proud to be the official mental health partner of the Canadian Olympic team. So today I'll be talking about a systematic review that I did when I was still at the Institute for Work and Health that was funded through CIHR, and part of the work was also funded through CREAM's Center for Research Excellence on Musculoskeletal Disorders at the University of Waterloo. And we'll be talking about developing interventions to prevent disability in older workers with or at risk of developing musculoskeletal disorders. But I'll also focus on people that have other conditions or no conditions at all, for that matter. So for the webinar, this is based on a half-day workshop. So I have to cram a half the day into an hour webinar. So please bear with me if I go a little bit too fast. So I'll introduce the people that helped me do this work. I'll introduce you to the method, the intervention mapping method. That was the ground idea behind doing this work. I'll lead you through the research methods that underlie the systematic review that we did. I'll do a little bit of a quiz where I have to actually hand back the presentation to Angie to make that happen, to get a little bit your opinion on what we know and what we don't know. So that's results on your knowledge, and then we'll more or less compare that to the results that we had from the research that we did. I'll try to wrap it up with a conclusion and an attempt to translate the findings to practice. And I will guide you towards some resources, and one of the resources will be the published review that's actually free online access at this moment. So our team. So that's me. Started doing this work when I was at the Institute for Work and Health in Toronto, currently at Morneau Chappelle. And then there's Kim Cohen, Emma Irvin, Dwayne Veneer, Dorcas, Peter Monici, Kwembe Mahuda, Sarah McDonald from the Institute for Work and Health. Mona Dalavinia, who did his PhD at the Erasmus University in Rotterdam, but who was at that time based at Khorasan University in Iran. Judy Geary as a researcher, she's still affiliated with the Pacific Coast University for Workplace Health Studies. And then Doug Rose from the University of Alberta, Martina Putz from the University of Toronto from the Faculty of Nursing, Heather Scott Marshall from Mission Research, and Amin Yazdani from the University of Waterloo. So our stakeholder team, there again, Judy pops up in another role. So she asked us if she could actually be part of the research team, and of course she's a former employee of the WSIB and has been a key figure in developing the new case management system there. Graham Lowe from the Graham Lowe Group, Greg McIntosh from CBI, Jan Chappelle from Canadian Centre for Occupational Health and Safety, Bruce Steven and Agatha Cameron from WCB in Manitoba, Mark White from CRRP, so this party goes back with his organization, and Jody Jacinta and Nancy Leslie from the WSIB, Judy McBride King and Carla Thorpe from the Conference Board, and Ron Saunders from the Institute for Work and Health. So a lot of people involved, so we got great feedback, and we hope that improved the process and the findings. So what is intervention mapping? Intervention mapping is a protocol for developing effective behavior change interventions. You can find more on it on the website interventionmapping.com. So it's actually a method to apply the research knowledge that's available and develop it into interventions that can actually be used in practice. So it's a 6-step method, and for this presentation, I'll be focusing with it's what I do for the workshop as well. It's really important that we know the context of the intervention, including the population, the setting, and the community. So you have to know where this intervention actually lands, because what might work in one context might not work in the other. So you really have to clarify the setting. And what we do in this webinar is actually step 3. We looked at the theory and evidence-based change methods. So we look at the interventions that actually are proven to be effective. And then there was another part of our study where we tried to look at determinants for behavioral and environmental outcomes. So we wanted to look at prognostic factors that determine retirement, but that's not going to be a topic in this presentation. But it's background information that you want to know to develop a successful program. So we used to do. So the first time I did this was in my half-day workshop at the Premise conference in Toronto last year. So we asked people to describe the context for the intervention that they wanted to develop, including the population, the setting, and the community. So that's something that you might want to consider. What's the intervention that you want to develop based on what you hear today? So next, we helped the audience to choose theory and evidence-based change methods. So we're going to present the findings of our systematic review, and then we're going to look at whether we can select or design practical applications to deliver the change that we're interested in. It might be that you see an intervention in this presentation that would really fit your context, that's proven to be effective in a very similar context, and that would really work in your situation, and that would make things easier to actually come up with an effective intervention. So these are the questions that we asked people just to guide the conversation and your way of thinking about developing an intervention. So we wanted them to discuss theory and evidence-based change methods among a group of peers. So what works in your experience and to your knowledge, so that's a little bit of a framing of your mindset. And we wanted them to discuss the context for the intervention. So what kind of worker population do you have? What's the setting? What's the wider context of what's the community like? And we wanted them also to think about whether interventions for workers with MSKs were different from interventions for workers with other conditions, because that was actually the topic of the conference that we were doing this workshop at. And we asked them, because they came from different countries, we asked the participants to discuss whether the setting, the community, or even the jurisdiction mattered for a particular intervention to be successful. So next is the research methods for the systematic review. Some of them might have seen this graph before. It's the steps of a systematic review and stakeholder engagement that's developed at the Institute for Work and Health. So along the process, even at the stage of developing the question, we met with some stakeholders to refine the question. We asked their input on how to search the literature, whether we were missing any topics in our literature search. Well, in our case, we actually had an embedded stakeholder, Judy Carey, who could really give us feedback at every step of the process. Sometimes some of the steps are more or less skipped. But in our case, in every step, we had Judy's amazing feedback to come up with interesting findings. So we're now actually involved. We're now at the stage where we want to disseminate, and well, Mark White from the CIRPD is now involved because we're presenting the findings in one of their webinars. So the research question that we're interested in today is what's the effectiveness of interventions aimed at return to work and or stay at work in aging workers? And the second question that we're not going to address today is what factors are associated with return to work or stay at work in aging workers? So what are the predictors for early retirement in older workers? So we were interested in workers that are 50 years and over, so what a lot of people consider to be the baby boom generation, born between 1946 and 1964. But we also included those that are younger if the research question was clearly focusing on aging workers, or if the workers were from a physically demanding profession, because in my experience, you can't really compare a 40-year-old construction worker to a 40-year-old office worker, because they have been exposed to very different situations. So we were very interested in more physically demanding professions. So the interventions of interest were either workplace-based, healthcare-based, or policy-based. In other words, I'm interested in whatever works. I'm not focusing on a specific discipline or setting. We're just really interested in to see what's effective, and I think that's important information, so we can actually make good decisions on this topic. So we looked at what we defined as return to work or stay at work. We all probably know the term return to work, so time on sick leave and disability benefits. We specifically excluded intention to return to work or workability, even though our stakeholders told us that workability was really important, but we considered it more to be a prognostic factor for a predictor of early retirement than an outcome in itself. And then we looked at stay at work, so that's those people that they're not on sick leave, but they're at work, maybe struggling, but they're still at work. And those outcomes include things like early retirement, a permanent disability pension in older workers, and maybe days off work during the course of the intervention. So they're at baseline, that when the intervention starts, they're not necessarily on sick leave. They can be just functioning but then they record the number of days that people are actually taking off over the course of the research. And here again, we excluded intention to retire and again workability, because we wanted to have some solid measures, some solid outcomes, and the link between intention and actually showing that behavior isn't as firm as we would like it to be, so that's why we excluded it. So we worked with levels of evidence for the evidence synthesis, where strong evidence can only be achieved when all studies are deemed to be high quality, and the minimum quantity of the number of studies is 3. That's somewhat arbitrary, but in our case it actually works quite well. So 3 high quality studies have to agree on the direction of the effect, and this would lead to recommendations for practice. When there's moderate evidence, there's only 2 high or 2 high quality studies or 2 medium quality studies, and 1 high quality study that supports the evidence, and then we would go to practice considerations. Anything less than that is limited, mixed, or insufficient, and it's not enough evidence to make recommendations or practice considerations. So we'll be focusing on the interventions that are supported by strong and moderate evidence, because we're interested in practice considerations. So we also did a white paper on specifically on musculoskeletal disorders and work participation in older workers. For that study funded through PMSD, we did a scoping review of the literature, and we built on previous institute organic reviews. So on the previously described larger CHR funded study, and we actually found there was a lack of literature examining interventions or strategies related to older workers in MSD. So that's why we did a scoping review to give it a little bit more breadth, so a little bit more of a context, and not necessarily focus on the effectiveness of interventions. So here's where we're going to do a bit of a quiz. So I would like to ask you in this quiz what you think is important or effective or not, and I'll have to hand it over to. Let's see what's on the next one. Oh yeah, to Angie. Did that already happen? I guess did. Yeah. So did I? Wait a second. Did I hand it over? I'll have to change the presenter.
Okay, so the audience should be able to see the first question on the screen. Is communication within the workplace effective? So we'll have about 10 seconds to answer.
I'm not sure if you can hear me now, but so it's really at the top of your head and just yes or no. Don't think too much of it. So please go ahead.
Okay, we'll go ahead to the second question. Is case management effective?
And that's to keep people in the labor force or get all the workers back to work.
Okay, we'll close that one. Is communication between workplace providers effective? Oh, and healthcare providers effective? Okay, I'm going to close that one shortly. Is exercise effective? Have about 5 more seconds. Okay, next question. Is early intervention effective? Get 10 seconds. Okay. Is the influenza vaccination effective? Okay, I'm going to close this one. Is a job task analysis effective? About 10 more seconds. Is information to patient and family doctor effective? 5 more seconds. Is a change in medication effective? I'll close this one shortly. Are modified duties or working hours effective? Five more seconds. Is psychosocial care effective? Now 5 more seconds. Is participatory ergonomics effective? Now 5 more seconds. Is making a return to work plan effective? I'm going to close this one shortly. Is subsidized physiotherapy effective? And close this one shortly. Is supernumerary replacement effective? Couple seconds on that. Is angioplasty more effective than heart surgery? Couple more seconds. Is Tai Chi effective? A few more seconds on that. Is vocational counseling effective? A few more seconds. Is worksite accommodation effective? This is the second to last question. A few more seconds on this one. And the last question, is worker education effective? Okay, this concludes the polling section.
Okay, so can you hear me? Okay. So this kind of show. This kind of shows you the diversity of all the interventions that we actually found in our review, and I really wanted to make you put you in a frame of mind where you're actually actively considering what might be effective and what not, instead of just letting me tell you what might be effective. So there's a lot of diversity in the interventions that people have developed and have studied to show effectiveness. Can we now show the results of the quiz?
Yeah, sure.
Okay. And it's just to give you a little bit of an idea. That I just want to know whether people find everything effective, or whether there's a clear trend in what people find effective. Organizers must show hide. Okay. So communication is 90%. Everybody agree, or most people agree that it's effective. So next one. I was hoping that it would be smooth sailing, but we have to work around it a little bit. Case management, 90% says it's effective. 91%. Okay, next one. Communication. Oh, that's interesting. So 45% says yes, and 55% says no. So that's interesting. Considering that I was just asked if I wanted to be involved in a study on communication. Exercise, everybody says of course, or well, 9% say it's not effective in all workers, but 91%, I think there's consensus there. So that's completely interesting. Early intervention, 97%, even better, agrees that it's effective. Okay, next one, influenza. So we even got things like influenza, and 69% actually says it works, and others say, well, I'm not too sure. But that's one of the studies that we found where they actually looked at influenza vaccination, whether it was effective or not. Next one, job task analysis, and people will probably ask me what do you exactly mean by job task analysis, but 90% of course that works to keep people in the labor force. Okay, next one, information sharing. This was a Quebec study, if I recall correctly, and this time 76% says, so it's perceived differently from communication. 76% says that yes, that will probably work. Okay, next. Change in medication, is that effective? Part of a geriatric assessment in older people is often that they screen the medication list, and that's highly effective in geriatric patients. We found one study that actually changed the medication in RA. 98% says that it's actually effective. I'm just wondering if some people actually wrote the paper and are thinking that this is a test. Modified duties, 93% says yes. Okay, next. Psychosocial care, 93%. I'm never really sure what psychosocial care means, but we agree that it's effective. Participatory ergonomics, something I can say because I actually did my PhD on a participatory ergonomics intervention. Return to work plan. 97%. Okay, great. Next one, physio, subsidized physio. Very specific study that looked at subsidized physiotherapy. And apparently there's a difference between subsidized physiotherapy and regular physiotherapy. So physio, supernumerary replacement, most people say it doesn't work. Okay, interesting. So, going in with a little tube or open heart surgery, so less invasive versus non-invasive, 90% says that works. Okay. Tai Chi, 82% says it works. Next one, vocational counseling, 71%. Oh, that's interesting. Work accommodations, they work in older workers, 100% says yes. There's consensus. And worker education, the last one. We were limited in a number of questions we could actually ask you through the system, so there were 4 more, but this kind of covers the whole thing. 92% says it's actually effective. Okay, that's interesting. So now we're going to look at what we found in the review. And show my screen. And what's happening now? Okay, there it is. So now we're going to the results of the review. So more or less comparing it to what you thought would be effective. So in the end, we searched. If you're missing one of the scientific databases, please let me know, because I think we covered most of them, if not all. So we waded through 11,000 titles and abstracts. A lot of them can already be excluded based on the title, and sometimes you have to go to the abstract, but sometimes it's very, very clear. In the end, we looked at the 203 studies that were about older workers and retirement. 14 of those studies were intervention studies, so those are going to be the topic for today. We found 69 studies that were about the general working population that we still want to take a closer look at. And there were 117 prognostic factor studies that were specific about a patient population. So if you're interested in patient populations, older patient populations, and return to work or stay at work, please contact me, and maybe we can give you a chunk of that data and you can have some fun with it. So we extracted the data from all those studies, so there's a lot of work that's already been done, and we completed the evidence synthesis, summary tables and reports. We actually wrote a paper that you can actually read, and maybe some looking at results, maybe some people actually already did that. So this is the places where these 14 studies were done. 1 in Canada, actually Quebec, to be specific. 5 in the USA, 1 Finland, Germany, 3 from the Netherlands. For such a small country, I'm always amazed. 1 from the UK, and 2 were actually international studies. So there were multiple jurisdictions where different countries were compared to each other. So this is just for your reference. If you want to check it later, you can also look in the paper. But this is just a quick overview that you can just steal if you get the slide deck sent to you. So from the 14 intervention studies, 4 were actually in a cardiac population, so people that were receiving cardiac rehab. 5 of them were in a general working population, so not necessarily on sick leave. 2 were on musculoskeletal disorders, so that wasn't really enough to fill a whole review that was funded to pre-MSD. So, and then there were 3 that were on rheumatoid arthritis. So we had to, as you've seen, there's a lot of different names for different interventions. So we really had to categorize and classify these interventions. So if you look at the orange part, number 2, 3, and 4, that's really the subdivisions. So we had a class that we classified as work modification, a class that was considered to be a healthcare-focused intervention, and then 4 service delivery-focused interventions. So in work modification, we would have a work satisfaction, job task analysis, modified duties, participatory ergonomics. In healthcare, it's very much in healthcare, integrated activity, exercise, surgery, physiotherapy, and then there were the service delivery focused interventions, return to work plan, case management, communication, early intervention. And then there were quite a few studies that actually looked at a combination of these interventions. So it's a little bit of this, a little bit of that, and make that into a package that, according to the developers, would work. So the ones in healthcare were, 3 of them were about medication. So one of them was on comparing 2 types of rheumatoid arthritis medication. One on vaccination, as you've seen, surgery, the open heart first, non-invasive, and exercise. One was on work modification specific, but quite a few actually looked at the combination of any of the above. 3 were specifically looking at return to work outcomes. 9 were looking at stay at work outcomes, which I thought was kind of surprising because I was expecting, because that's the world I'm from, I was expecting the main bulk of studies to actually look at return to work, but quite a few actually looked at stay at work, so early retirement in specific, and 2 studies actually looked at both, so that's just amazing. I think people do both of those. Let's see what's happening here. Okay. So this is the findings in a table. So we could only find moderate evidence, positive evidence for multi-component intervention. So the studies that actually did a combination of the classes that we identified. 2 of them were high quality, and 2 of them were medium quality. And there were 5 studies that looked at multi-component interventions, but one of them showed to be not effective. But so our advice is that multi-component interventions could be considered to be implemented in practice if it's applicable to the work context. So the context again is very, very important. Limited evidence is medication use or the change in medication, cardiac surgery, and even exercise, education, and work accommodation isn't supported by sufficient evidence. But that's in a lot of these cases, it's really very much because not enough studies actually have been done on the topic. So it's really a lack of evidence. It doesn't mean that they're ineffective. There's just not enough studies out there that support any advice on these interventions. Just to remind you, so we have to have 3 high-quality studies to actually come to a strong level of evidence that we consider to be strong, and that leads to recommendations. So we could only get to practice considerations for this study. This is a quick overview of the studies that we found. So, study by Allaire in rheumatoid arthritis, looking at job retention, vocational rehabilitation when at risk. So the vocational rehabilitation actually works, and it's considered to be a high-quality study. Then the study by Angela de Boer from the Cornell Institute in the Netherlands, an occupational health program for those people that are considered to be at risk, and the occupational physician and the workplace were involved. And then there's this guy from the Netherlands that did a subgroup analysis on participatory ergonomics and coordination of services. This study was deemed to be of medium quality. Of course, if you don't agree with the reviewers and say that it's high quality, you can actually get to a strong level of evidence. I'm not going there because I was totally not involved in assessing the quality of the study. And then there was the study by Shukla in the general working population, where they focused on seniors and the workplace was involved, but these people weren't specifically at risk. And then there's the Quebec study from Canada, multidisciplinary cardiac rehabilitation, structured return to work program, and the healthcare provider, the family physician, was informed about what was happening and that this person was supposed to be back at work, and the workplace was also involved. So then we had the white paper that was led by Dwayne Van Eert, funded through PMSD. The results was, well, it's pretty clear that an aging workforce is a reality. Very important point is that there's great heterogeneity of older workers, and it's much greater than that of younger workers. A biological age doesn't tell you too much about how old someone is when they're over 50 in the workforce, because people have very different experiences. We found individualized agreements, ideals as they were called by the authors, are a key aspect of workplace policy to support healthy aging. So healthy aging, there's consensus that it's beneficial for productivity and for society. There are some feasible approaches to maintain older workers in the workforce for both musculoskeletal and other health conditions. We found that the World Health Organization has some really good strategies that could be used as a starting point. And of course, as researchers, we really like the recommendation that more research is needed. I provided a link to the white paper that Dwayne and the rest of the team wrote on the PMSD website, but the link is they should work on their link because it's impossible to actually copy paste. But probably if you go to the PMSD website, you should be able to find it because it's up there. So the conclusions: there's a vast body of research on work participation of older workers. As you might have noticed, the terms that we use have shifted a little bit. We're now talking about work participation, not just return to work and stay at work. And we're no longer calling them aging workers, but older workers. There's only a few high-quality intervention studies out there. And then multi-component interventions could be considered to help improve work participation in older workers. In the effective interventions that we found, healthcare professionals and the workplace are both involved in effective interventions. So it's not whether healthcare is effective or that the workplace-based intervention is effective. The combination of the two involving all stakeholders makes interventions to be effective. And the effective interventions actually focus on high-risk cases, so either people that are on sick leave, are in cardiac rehabilitation, and those people where they actually ask, do you think will you actually make it to 65 to retire? So in the Boer study, for instance, they asked people, are you going to be okay until retirement age? And then they invited those people that said, no, I think I'm going to be in trouble, to the intervention and randomized them. And they found that you can actually be very effective in those people that report that they are at high risk. Very simple question that they posed for them. So similar interventions seem effective among all populations, regardless of age, because they're very similar to what we also find in reviews of effectiveness of return to work interventions, for instance. So the paper was published in a special issue of the Journal of Safety Research, and the last time I checked, which was last week, it was actually a free download. And I'm not sure whether that was because of some special week and it was funded through NIOSH, or whether they actually paid the money to actually make it free online access all the time. So you can always read up on it by going to that link that I provided. So the recommendations is multi-component interventions could be considered depending on your context. If you read the paper and see how they organize those interventions and say, well, that really doesn't work in my context, and you should probably not do it. But if it makes sense to you with some tweaking, you could actually make it fit to your setting. So vocational rehabilitation, worker education, return to work plan, case management, communication between workplace and healthcare provider, and modified work hours after an initial assessment. And of course, with that last one, those modified hours, in a lot of cases, shouldn't be forever. Sometimes it's just a temporary bridge solution to actually get people back to a state where they can be fully productive again after return to work, for instance. It seems to be best to focus on high-risk cases to improve the ability to work in the near future or until retirement, which might actually explain some of the other findings of ineffective interventions, like the exercise isn't really supported by evidence, but that could also be because those studies really had a very broad population that they focused on, so just a general working population, just over 50, where you run the risk that you're actually attracting people that in the end don't really need it, but were physically active anyway. So the focus on high-risk cases, which doesn't mean that you should exclude other people from the intervention, but you're most likely to be effective in those cases that are at high risk. So where interventions in return to work are often reactive, somebody calls in sick and all hell breaks loose, there has to be somebody else that does the work and things like that. Interventions in stay at work, so helping people to reach their preferred retirement age, can be very proactive, where you actually sit down with the worker and have a talk about it. Stressing that the lack of evidence is not an absence of effect doesn't mean it's not effective, it just means that there's just not enough studies out there. And I urge people to be creative to create evidence-informed solutions if possible. Recommendations from the white paper. Enabling autonomy can support older workers to work longer. Supporting healthy aging in policies, so workplace policies that support accommodation and development are needed. Older workers still want to keep learning. It's often that they just learn it in a different way. And in the end, there's inconclusive evidence that MSDs are more prevalent in older workers, or that older workers are less productive, which is very contrary to the general perception. I think there's some work that it doesn't necessarily mean that older workers are less productive. There's just really not enough evidence for that, and that might surprise you. So, how does this translate to practice? So this is where I'm at now, and it's also because I started working at Chappelle, where they're interested in this question too. So my idea is that talking about the high risk, that it's really mostly affecting in high risk cases. So how do you get to those high risk cases? So that there might be people that more or less self-refer. Could be that they actually call in sick quite often, and they're picked up in your absence tracking system, and you might want to invite them over to have a chat on how things are going. There could be manager referral, where a manager says, well, this person is clearly struggling. In our experience, that might actually mean that some people might need some training to start that conversation in a polite manner. It could also be that you maybe do an employee survey where you actually ask people that are over 50 a question similar to what they asked in the randomized control trials. Do you think you'll make it to your preferred retirement age? And based on whether they answer yes or no, say, well, maybe we should have a chat about that. So then we'll get to, and based on those screening mechanisms, we can determine whether people are low risk for premature retirement or at high risk for premature retirement. And maybe they have some caregiving issues, which could be solved by an employee assistance program. Maybe they have some health issues where they say, well, I really should get fitter, because the evidence might not support exercise, but that's because those trials actually didn't focus on high-risk cases. They just offered the opportunity to everyone that was over 50. And then you can do some very specific fitness coaching and accommodation to help these people at risk to reach their goals. And in the end, working at Chappelle, we realize that some people might have the financial opportunity and some might not have that financial opportunity. because we all these researchers think that we work to get healthier, but in the end, of course, we all work to pay the mortgage and to make a living. So some people might actually be able to afford a retirement and some might not. And it might actually make sense to have a little chat about financial planning and whether people can afford their retirement. Some people think that they can, and in the end might not be as positive as they think, or the other way around. And of course, in the end, there's people that you might still want to provide all the services that they're interested in, but they will retire as usual and just go on to lead a happy and fulfilled life even after retirement. So here are some resources. The Centers for Disease Control and NIOS in specific have some really interesting websites on productive aging. There's the Age-Friendly Workplace website that gives some really interesting case studies on how to do that. Then there's the Europeans that are looking at occupational safety and health management in the context of the aging workforce. Interesting website. In Canada, we now have a National Institute on Aging at Ryerson, where I worked for a year. That are also interested in these questions that once in a while have some interesting information. Then there's the World Health Organization that has a world report on aging and health. That's a really good read. And then there's a book called Aging Workers and the Employee-Employer Relationship. Yes, there are a lot of Dutch names, and one of the editors is Denise Rousseau, who's one of the leading figures in evidence-based business management. And that's a really interesting book and a good read. Slightly different perspective than the work and health perspective, so that makes it even better. So you can also keep up on evidence-based practices from the Institute for Work and Health. Whole bunch of thing here. I added the white paper link at the University of Waterloo. As you can see, it's a bit of a long link. I hope you're able to actually copy paste this and look for it. But a Google search might actually get you there too. So if you Google, I think Blaine van Eert, pre-MSD, white paper, MSD, then you might actually get there too. Okay, so that's it for me. I think we have time for
Thanks, Siobhan. Now we have time for some questions and answers. If anybody has any questions, please enter the questions into the question box of the GoToWebinar panel. That way we can answer them out loud. Some questions that did come in: can I print the presentation? For all of our webinars, we do provide a PDF copy of the slides. So you can find that on our website about a week following the event, and registrants will be emailed when the materials are available in a follow-up email. Another question that came in is, what are some practical solutions you came across as part of your research study for stay at work?
If you look at the trial, the randomized control trial that I like best, if you can call it that way, is actually the study by Angela de Boer, where the occupational physician actually was actively involved, and they focused on people that were at high risk, and they really sat down with the occupational physician and the workplace and the worker to come up with accommodations and maybe adjustments in working hours that made it possible for someone to actually reach the retirement age. So it's really all about having all stakeholders involved, and it's an old story, and maybe it's because I was partly trained by Patrick Loisel with involving all stakeholders, and you might have seen the figure numerous times. It's really about involving all that are important in the process and come up with a shared solution, and probably be proactive at it. So that's what I liked about the Boer trial. They didn't wait until things went wrong. They made it part of an annual assessment and asked people, well, how are you doing? And based on that fact, they started working on solutions. And of course, I kind of like the participatory ergonomics approach because, yes, that's me, and that wrote that paper in 2009. And that's again where you involve all the important stakeholders and sit them down, and it's only a half-day sit down with several stakeholders, and then coming up with solutions, and actually tracking whether those solutions are being implemented. That seems to really help, specifically in older workers. So it's really all about not being shy to invite people that are important to provide solutions, and it's not that are not shy to actually come with solutions that might be a little bit out of the box, and really make it work, and come with a shared solution at the end.
Okay, great. Another question is, where can you mentioned there was a lack of high quality research. Where can we find other organizations who do provide high quality research or materials?
Well, so the question about high quality research it's really about how we as researchers assess our peers. And as I already said, we want to have the randomized control trial, so with a decent control group and an intervention group. And so in the end, we say that the quality might be medium or low. It's really these are like the ones that I'm not sure if the multi-component interventions that I'm showing are all very, very, very decent, but they just don't meet standards like double-blind placebo control. So we're always very harsh on our peers. But I think this is the best evidence you can get, as far as I'm concerned. And there might be other people that that have some high-quality evidence as well. I'm just now wondering whether someone at the Cochrane collaboration is asking this question. Mm-hmm. Hi, Danny. But that's a really good source if you want to know about what's effective in the workplace.
Okay. And we can include your links within your presentation along with the follow-up materials for our audience.
Yeah.
I think that it concludes for questions. Do you have anything you'd like to add?
Well, if people have any questions in the future, you can always contact me. People are always a little bit hesitant to contact researchers because they think we're high above in a big cloud, thinking up really important things. But you can always contact me. In the end, I think it doesn't happen enough. So the only people that ask me about my research are people that do research. And I'm very interested in collaborating with people and giving some answers to it.
Awesome. Well, thank you very much for your presentation.